Assalamu alaikum. I am DrNAS, and again we are here with the remaining topic of heart failure. We will complete it into the 5 to 6 lectures. Today is the third lecture. Today we will cover the in last lectures we have covered the pathophysiology of the heart failure, the types of heart failure, stages of heart failure. Now today we will discuss about the sign and symptoms of heart failure and few of investigation, what investigations we can do and why we do such investigations in heart failure patients. So without wasting the time, we will move towards the investigation of heart failure. First of all, sign and symptoms of heart failure. Usually we will if we discuss and if we name the heart failure, it means that we are talking about the heart failure of all types, like heart failure secondary to valvular diseases, heart failure secondary to diastolic dysfunction, heart failure secondary to reduced ejection fraction, heart failure of any type. Whenever I would discuss or name the heart failure with HFrEF, like heart failure with reduced ejection fraction, it means I am discussing the heart failure secondary to systolic dysfunction. So here we are discussing about the heart failure, like the generalized heart failure. What would be the symptoms of the heart failure? First we will discuss about the symptoms and then we will discuss about the signs. So in symptoms, obviously the dyspnea is the most common symptom of the heart failure, but it is less specific and less obviously it is more sensitive, but it is less specific for the patients. But in dyspnea, if your patient has orthopnea, so orthopnea is 90% sensitive and 90% specific for heart failure. If your patient has orthopnea, then it is the 90% sensitive and the 90% specific for the heart failure. And after orthopnea, if your patient has developed the PND, proximal nocturnal dyspnea, or Cheyne-Stokes breathing pattern dyspnea, then obviously it means your patient has heart failure, or that heart failure because of any etiology is of any etiology. Okay, so what else your patient can complain with the heart failure? Your patient can complain about the syncope, and that syncope because of the arrhythmia. As you know that in the low ejection fraction, or if your patient has a heart failure, then he or she may develop the arrhythmia, or heart failure may be because of any arrhythmic disease such as the arrhythmogenic right ventricular dysplasia or ARVD or any else like tachy-induced cardiomyopathies. So your patient may complain or present with the syncope with the signs of heart failure. So other symptoms may be like bloating, constipation, peptic diseases. Most of the time your patients complain about the constipation with the heart failure because of this because of swelling or the like edema in the intestines. Edematous intestine causes what? Constipation in your patient with the heart failure. That's why, so please don't neglect the constipation, the complaint of the constipation with the heart failure, or anorexia or a loss of appetite with heart failure. That is same because of the edematous intestines in your heart failure patients. So that might be the cause of the anorexia or the loss of appetite in your heart failure patients. So you have to take very serious each and every complaint of your patient with the heart failure. Now we will discuss about the signs, what signs you can find in your patients on the clinical examination. Obviously on looks you have to see that weight gain. Weight gain is a very sensitive indicator and the marker of the heart failure. You can see with your naked eyes the third body spacing, pedal edema, or the facial puffiness. You can see that. Sometimes you can you would have the audible wheeze or audible craps in your flesh edematous patient, or in the flesh acute pulmonary edema patients. You can get the obviously the weight gain in the chronic heart failure patients, or you can these are the examination on the general physical examination. Audible wheeze or craps, okay, And what else you can get your patients? Obviously JVP. Most of the time JVP would be raised in right heart failure patient, okay, or weight gain or anasarca, like generalized body swelling, would be because of right heart failure, because left heart failure give you the signs of the pulmonary rales or the crepitations in the lungs, but you cannot see the crepitation in the lungs with the naked eye. So, but you can hear the crepitations in the flesh acute edemas, pulmonary edemas. So it might be the sign of the left heart, but these would be the most of the signs of the right heart. But because of the left heart, you know that right heart would also be failed. So most of the time you will get the ventricular failure. So in heart failure you would get the anasarca, audible, wheeze, crepitations, and the JVP. And JVP is obviously is an indicator for the heart failure, but it is obviously shows the right heart failure. Okay. So then the JVP when you check the JVP, you do the hepatojugular reflex. What is the hepatojugular reflex? How you would define it? By pressing the right hypochondrium area. If you would get the more than 4 centimeter of sustained GVP, it means your it means that hepatojugular reflex is positive in your patients, and it shows that it shows that it actually increases the sensitivity of JVP. If you want to check the JVP, and if you are not getting the JVP, then if you want to increase the sensitivity, then you have to do the hepatojugular reflex. What is hepatojugular reflex? To press the right hypochondrium of the patient. If you get the more than 4 centimeter of JVP, sustained JVP, then obviously it is if you get the sustained increase of the 4 centimeter JVP, it means your hepatojugular reflex is positive. So what else you get, as we discussed, that the pedal edema and facial puffiness, ascites. You can get the ascites of the patient, and again that all the body swellings in the right heart is because of the right heart, okay, except the lungs, because obviously if your left heart is failed, then the blood would be pooled in the left atrium, and from the left atrium it would increase the pressures in the pulmonary veins, and pulmonary veins obviously increase the pressures in the pulmonary capillary wedge pressure, which causes the pulmonary edema. So the third heart sound, obviously now on the auscultation you will get the third heart sound, gallop sound. Gallop sound is most of the time because is like the sound of running, like gallop. What is the meaning of gallop? It's like the gallop means the running of horses. You will get the sign of like this, like S1, S2, and rapidly after the S2 you will get the S3. So that would be the sound. I just want to so the third sound actually which you are listening here, as you can easily appreciate it, that it is the sound which is very similar when you will hear the galloping of the horse, or you can Google it by just writing the S3 sound, S3 gallop sound. So you would appreciate this sound, and when you will auscultate your patients with the heart failure, you will get, most of the time you will get this S3 gallop. Okay, now which type of pulse you will get here the most of the time pulses alternance. It means sometimes you will get the slow pulse and sometimes you will get the high pulse, just because of the low ejection fraction. Your patient is failed to give the output of the same output in the every beat. That's why you will get the very slow rising pulse, very sometimes you will get the you will get the pulse with the different volumes actually. So that would be the pulse with the patients of heart failure, because your heart is fail to give the normal volume with each beat in the system. So hypotension obviously is the very poor prognostic marker, and you easily get the hypotension in your patient because of the failing heart, because you know that the failing heart is incapable to maintain the blood pressure in your system or in your arteries. So these would be the sign and symptoms of your patients with the heart failure. Now we will discuss about some of the investigations, which is actually the main important discussion of today's here with the heart failure. Investigations. obviously the very important is metabolic profile. Metabolic profile, obviously you would send, I think we all people do send the metabolic workup and the baseline of our heart failure patient when we get admit them, or whenever we would be looking them or examining them in our clinics. Obviously you would send the CBC. Why CBC? In CBC you have to see the hemoglobin. Okay, in CBC you have to see the hemoglobin, and hemoglobin, you know that it is the most common error, or it's not actually error, but it is common finding which you would get in the heart failure patient is low hemoglobin. It is because of the chronic disease, anemia of the chronic disease, or sometimes iron deficiency anemia if your patient is on the blood thinners or all this, but most of the time the heart failure you would get the anemia of the chronic disease. And low hemoglobin, obviously it is a poor prognostic marker, and as we discussed in our last lecture that confirm HF trial and fair HF trial, confirm HF trial and fair HF trial, these both trial actually supports the iron replacement in the iron deficiency anemia in heart failure patients. Okay, so if your patient has a iron deficiency anemia or anemia of chronic disease, low hemoglobin with no any other cause, then you can transfuse the hemoglobin in your patients, and these trial actually support this intervention, confirm trial and the HF trial. What else? And up to the 40% of the patients, with the heart failure have low hemoglobin, and is that, as we discussed, that low hemoglobin is because of anemia of chronic disease. What else? Hemoglobin and TLC. TLC is most of the time is a predictor, or it supports the diagnosis of, or it supports the triggering factor, because whenever your patient would be on the stable heart failure and now he or she is presenting to with the worsening of the heart failure, you have to rule out the trigger in those patients. So TLC tells us about tells one of the triggers in the heart failure patients, and TLC shows that might your patient would be infected, and now he or she is presenting with some sort of infections. And low platelets, again, most of the time low platelets is not the common finding in your heart failure patients, but obviously if you are finding such any other like remarkable finding in the investigations, you have to elaborate and you have to rule out them. So now what else you can go in the metabolic profile? Obviously electrolytes again are the very much important for us. As we discussed the CBC, now electrolytes. In electrolytes, sodium obviously is a poor prognostic marker. If your patient has a low sodium, hyponatremia, then obviously or any abnormality most of the time you would get the hyponatremia, and that hyponatremia because of the hypervolumic state, high volume states. Okay, so and it is again the poor prognostic marker in your heart failure patients. You can get the hypokalemia or hyperkalemia in your patients. Okay, that hypokalemia, that actually hypokalemia is because of excessive diuresis which we do in our heart failure patients, so we can get the hypokalemia, and that actually electrolyte imbalances actually can worsen the heart failure of the patient. Okay, because this hypokalemia can cause any arrhythmia, or this hyperkalemia can also cause any arrhythmia which may trigger the heart failure. So that hyperkalemia is because of the aldosterone blockers or any RAS system blocker like AC inhibitor and ARNI. All these agents can increase the potassium, so we have to check the electrolytes in our patients. Okay, now we have done the sodium and all these things, so we have done all these things. Now what else we have here? We have to send the TSH. As we discussed that sometimes thyroid profile is very helpful in with us, with those patients who have a dilated cardiomyopathy with no other cause. Then you know that hypothyroidism and the hyperthyroidism can also cause the heart failure, and it can also, if your thyroid profile is worsened, like for suppose if your patient is hypothyroid and now he or she is on the thyroid replacement therapy and he is presenting to you with the worsening of heart failure, then you have to check the thyroid profile. If he or she is not taking, you have to exclude it, that is your patient is not taking the high dose of the thyroid, because high dose of thyroid may cause the hyperthyroidism or hyperthyroid induced tachycardias and all these things, and these things may worsen the status and the stable heart failure, and it may prone your patients to develop the worsening of heart failure. Okay, and sometimes if your patient is hypothyroid, or if suppose if your patient is hyperthyroid and you are giving him or her to the blocking thyroid blocking drugs, so you have to check it out that is your patient is not in the thyroid crisis. Okay, so again the thyroid profile is very much important for us to get done in our patients. Now the very important thing which I want to discuss with you guys is BNP. Why we have to, and what is the significance of BNP? Actually BNP is not very important to diagnose the heart failure, because heart failure is a clinical diagnosis. Heart failure doesn't need anything to be diagnosed, but the cause of heart failure, the etiology of the heart failure, the thing which actually worsen the heart failure, for all these things, for getting the information about all these things, we have to get done these investigations. Now the BNP, what is the role of BNP? Actually BNP doesn't is not remarkable, and it is not helpful to diagnose the heart failure actually, but it can exclude the heart failure with other causes. If you are confused that your patient does have heart failure or something else, then you have to get done the BNP or NT-proBNP. If your patient's BNP is more is like too much high, so you cannot say that your patient is not in heart failure. But obviously the BNP and NT-proBNP has some issues with that, because sometimes these raised BNPs are because of the non-cardiac causes, as here are a lot of things which actually affects on this BNP levels. First we have to discuss that the normal BNP levels. Okay, so the normal ranges are, in the normal range of BNP is 100, is less than 100. Okay, 100 microgram. And NT-proBNP, the level of NT-proBNP is less than 125. Okay, picogram. So these are the two things we will discuss in detail, that from where these BNPs are coming in our body. Okay, first of all, just do remember the levels, that the normal level of the BNP is less than 100 and NT-proBNP is less than 125. And if your patient if the age of your patient is, so 125 is for the age less than 70, more than 75. Okay, but if your patient's age is less than 75, then the normal NT-proBNP will be 450. So see that there is a very big difference between the NT-proBNP levels in different age groups. If your age is more than 75, then the normal level of the NT-proBNP, sorry, I'm just confusing here, because in elderly, actually the concept here which I want to explain you guys is that the elderly population has raised BNP, because BNP is nothing, it is a stretch on the atrial tissue which causes the natriuretic peptides, which causes the increase those hormones which increases the natriuresis. Natriuresis means increased sodium, the loss of sodium in the urine, and BNP actually is beneficial for our patients, and BNP decreases the symptoms of heart failure. Okay, that's why body increases the levels of BNP in our body, so to protect our body from the with to protect our body with heart failure, the symptoms of heart failure, by reducing the sodium in the water in our body. Okay, so if your age is less than 75, then the normal value of anti-proBNP is 125. But if your age is more than 75, it means you have normally you would have, if you are more than 75, if your patient is more than 75, then you would have a normal levels of BNP is around 450 picograms. Okay, so you have to interpret these results according to these normal levels. So what are the causes what are the causes, non-cardiac causes of increased levels or raised levels of BNP? One is increasing age, second is anemia. As you know that the increasing age is again the most common, and it is again the poor prognostic factor. This is again another poor prognostic factor, and most of the time your heart failure patient would have an increased age and anemia. So obviously your the BNP which you gonna do in your patient would be falsely high. And the worsening of renal function. Again, that is the same thing which most commonly occur in our heart failure patients. So you would get probably the raised or the falsely raised level of the BNP in your heart failure patient. That's why it is not necessary to get done the BNP in your heart failure patients. Simply is that. So, but if you want to rule out some other causes, or if you just want to exclude the heart failure, then you have to get done the BNP levels. If your BNP levels are not such high, it means your patient is not in the heart failure, and you have to exclude the other causes. So this is done, I think, but there are some patients in which you get the low levels of BNP. If your patient is obese and with the symptom of heart failure, then your patient would have low BNP levels. So you have to check it out that the obese patient with the decompensated heart failure would have low BNP levels. Okay, so I think we have done here. Now the important thing is that if you want to do, if your patient is on DrNAS, what is DrNAS? You know that DrNAS is ACE receptor blocker plus neprilysin inhibitor. Okay, the AC inhibitor blocks the RAS system, and neprilysin blocks the neprilysin receptors. Why it is very necessary to block the neprilysin in our body? Let me explain you first this thing and function of the DrNAS, and then we will discuss about why we cannot do the BNP levels in